contributing to the got it. So we were saying that we're going to delve now into the ways of thinking about classifying personality disorders. And so if we think about the 5-factor model, we can understand that a little bit of neuroticism, a sort of anxious, focused way of being, could lead you to be could lead you to be a little bit more responsive to social norms. So feeling a little shame about certain kinds of behaviors may keep us all sort of within the social contract. However, being very highly neurotic may lead you to feel too ashamed to try new things or make new friends. You can see that being a little extroverted might be really socially helpful. Being very extroverted might lead other people to find you distracting or even far out from the group. Being a little open, being a little more open might make you creative. Some of the best thinkers have had ideas that other people initially found kind of eccentric. Being extremely open might lead you to be actually open to so many different ideas that you can't make judgments that would be helpful to you in discriminating what to believe in. And you can see these kinds of things where a little bit is probably good, moderate may even be useful, and then being extreme may be far too much. I need to plug in my computer, so if anybody has a question, that would be a really good time. Okay. Another way of thinking about personality is to start broad and then narrow. So if we start broad by the DSM alternative model, we would start with sort of how's it going overall in terms of, do you feel like your identity is stable? Do you feel like you can count on yourself to be the same you from day to day? Do you feel like you have goals that you can pursue and that you continue to want to pursue over time so that you can feel some continuity, which is reassuring and stabilizing for most people? And do you feel that you can connect with other people to make rich relationships? If there are difficulties here, then we would want to get a little bit more specific in step 2 to think about the features that are causing this kind of difficulty. And these are really pathologic descriptions of extreme 5-factor personality traits, I would say. So this is really neuroticism, and antagonism is really the opposite of agreeableness, you can see. Then if we get even a little bit more specific, here's the first time we might introduce the names of specific personality disorders if we get all the way down to step 3. And then we might come back, zoom out a little bit more and say, okay, like how impairing is this personality disorder? And then we might think about other things like how much is somebody able to be a little flexible despite all of this going on? How sort of overshadowing is this in their whole life in terms of pervasiveness, the stability, and then other potentially contributing factors like cultural factors that may cause someone to act differently than the way that someone may act in another culture, or differences that are appropriate for teenagers or for very old people or something. And so you can sort of move through these steps, starting broad, narrowing, and then thinking about specifiers a bit. The most medical model for thinking about personality disorders is medical in the sense that it's very classified. There are lists of criteria that you have to meet, and there are groups and subgroups. It's not a medical model in the sense that we do not have a known physiologic or biologic explanation. So I sometimes think of us in the personality disorders, and really in psychiatry in general, in being in this place. Evan and I were talking about this at the beginning of the talk, being in a place where we have so much to learn. And so in some ways this is exciting, but in another way, we're at the level of thinking about dropsy. So dropsy was this diagnosis that meant that your ankle swelled and you swooned. And of course, we all know now that you can have lower extremity edema from having kidney problems or liver problems or heart problems or vascular insufficiency, or maybe from getting a bad bee bite on one leg, right? You could get lower extremity edema for a range of reasons, and we would care about why. And now in psychiatry, what we have is the shape of the disorder. We're able to describe the phenomenology, but we're not at a point of describing underlying physiology with any kind of specificity. So for anybody interested in getting involved in research in this area, please talk to us after. But I'll say the broad classifications in the psychiatric nosology and coding for personality disorders are these from the Diagnostic and Statistical Manual, the DSM, which is our sort of classification Bible in medical psychiatry. And so cluster A, the people who are odd and eccentric, perhaps withdrawn a little bit from others, perhaps a little unusual. So people who are schizoid are often described as not having friends and not wanting any. People who are schizotypal, the most common public presentation of being schizotypal would be psychics. There are other kind of classic groups. We're going to talk more tonight about borderline personality disorder, and the reason is we know the most about it, and also I in particular know the most about it. We're growing in our understanding of narcissistic personality disorder and antisocial personality disorder, but the other personality disorders in terms of treatment were far behind in terms of effectiveness. I'll just gloss over these and we'll leave them on the side. These are the DSM definitions for these personality disorders. I'll make note that it's probably worth for clinical work in any field learning a little bit about what antisocial personality disorder looks like, because the kind of charming presentation of someone who has very little regard for your needs or for the needs of other patients can lead to a lot of difficulty in your practice in any specialty. I would also say that narcissistic personality disorder can be managed quite well if you have a little bit of an ear, an antenna up for the kind of grandiosity and easy emotional injury that these patients can sustain. Okay, so we've talked about personality organization, and now I'll just switch over to talking about borderline. So we've come a long way in our understanding of borderline personality disorder in the last 30 years or so, largely to some work that happened at McLean Hospital. John Gunderson and others were able to define that BPD is really common. About 1 to 5% of people in the general population, and as many as 1 in 5 people in psychiatric settings have this disorder. It's almost as common in primary care settings where people return with the same complaint, being inadequately treated. So people are treatment resistant with almost any medical complaint, are much more likely to have borderline personality disorder. It's quite heritable, somewhere between the heritability of major depression and the heritability of schizophrenia, more than 55% heritable. And the likelihood of attempting suicide or completing suicide is markedly increased in people who meet criteria for BPD. So we should be very interested in this. It's frequent in our population and it's a risky state. Importantly, and this is data from Mary Zanarini's study at McLean Hospital over the last 30 years. I'll invite you to look first at the blue line here on this graph. And so what this is 300 people who were admitted to the inpatient unit with a diagnosis of BPD at time 0. And then you can see the percent of people who remitted over time. So this means that there are 9 DSM criteria for borderline personality disorder. If you meet fewer than 5 of them, you have remitted because you're no longer meeting the full syndrome. And so this is the fraction of people, or the percent of people who have remitted. And you can see that remission is fast and it's frequent. By 5 years out, more than half of people have remitted. By 10 years out, somewhere in the high 90s% have remitted. So people remit often. This is news to us. Many of the psychiatrists who trained me, who trained 30, 40 years ago in the previous generation, were taught that this was incurable and it never got better. So this is really exciting. And this is one of the sort of pieces of news that we need to get out into the world. Importantly, though, recovery, which here has a fairly stringent definition, so sort of getting back to life in the sense that you have an emotionally sustaining relationship outside of your family and you have full-time work or full-time school. This is also grows over time, but is less frequent. And this gap between remission and recovery should be a driving force for the next generation's work. We need to understand why people are having so much trouble getting back to life despite having fewer and fewer symptoms over time. And one suspicion about this is if we look at the criteria. So let's ask ourselves, what are some of these criteria that people have for BPD? We can put them into 4 big chunks because it's hard to remember 9. So one is affective symptoms. Your mood is up and down from minute to minute or hour to hour throughout the day. You go from feeling fine to feeling angry, to feeling despairing and sad, to feeling so anxious you're crawling out of your skin, and so on. Also, chronically depressed or anxious mood. Emptiness, which we might think of as sort of having no there in terms of yourself. These are people who, when we ask them, what kind of person are you? Pause and wait and then start to cry, because they know that other people would have an answer to this question and they don't feel that they have a solid self. People who respond to stressful circumstances with impulsive and dangerous attempts to feel better, getting angry, driving far too fast, finding unsafe sexual partners or unsafe sexual situations, using alcohol or drugs in impulsive and unsafe ways, spending money they don't have on things they don't need or can't afford, impulsively self-harming. Cognitive here means perceptual disturbances, a little bit of a misnomer, I would say, but people who have odd ideas, we would call this also the psychotomimetic symptoms, things that are like psychotic symptoms and in the moment can look just like the symptoms of schizophrenia, and profound interpersonal difficulties. So to come back to this question that we were looking at a minute ago, which is what's up with this gap between the frequency of remission and the frequency of recovery? What I would ask you to do is just take a moment and look over these symptoms and pick 2 that you'd like to start living with. And I don't mean to be cute about this, but I think it's really helpful to think about this because people who are by definition in remission may still be living with 1, 2, 3, even 4 of these symptoms, which could be, as you imagine, as I imagine living just with the changeable mood, I imagine that this would be very disruptive to the way that I go about getting through the day. And I think most of us can also notice that for most of these symptoms, they're not things that are fully outside of our experience. I bet most of you have had a time when it was really hard. Maybe school had gotten really stressful. Maybe there was a global pandemic. Maybe you were going through a relationship breakup, and maybe you found your mood was more labile for a while and you felt out of control. Or maybe you felt sort of less sure on your feet as a person. Maybe you found yourself doing risky things that you wouldn't have otherwise. And so I think it's also important to notice, like, this kind of state is one that many of us have experienced at least some parts of or a lot of parts of. And many of us in this room might have experienced even the full syndrome. It's pretty common. And so thinking about as it gets better, living with just a little bit of it is still a lot, and it's still quite disruptive. Okay, so now I want to show you a little bit of science. And as we talk about the science, I invite you to think about, and I'm going to try to talk to you about it in the way that I might introduce it to one of my patients, because I think you can introduce it to your patients, and this might feel good. So people with BPD feel left out a lot. And patients will tell you this, that they feel left out, they feel abandoned by the people close to them, and that other people have told them that they're making it up and that they should just settle down. And these data suggest that this is a real feeling at a biological level and that it's shared by many people who have BPD. So this is a cute little computer game called Cyberball. And what happens in the game is that these little guys, player 1 and player 3, are your game partners, and your player 2 and you're waiting to get the ball. And so they're like throwing the ball to each other, and it looks kind of dumb, but it's kind of compelling. You're watching it and you're waiting to get the ball. And at first they're concluding you, they're throwing you the ball. And maybe even at first the rule is pass to the left. And so maybe at first, you know, you're going to get the ball every third throw, because like player 3 is always going to throw it to you. But then they leave you out. They stop throwing you the ball. And most people, most healthy people, and even more in BPD, report that they feel super left out. It feels bad. The signals on this sort of lie detector measure this sweat on your palms increases. And ostracism signals in the brain, both by EEG and MRI measurements, suggest profound feelings of unfairness. In BPD, it turns out you need to get the ball 80% of the time to not feel excluded and to not have those physiologic signals of feeling excluded. And let me be clear, people with BPD are not bad at math. They understand what percent they're getting the ball. And so there's a disconnect between the fact I'm getting the ball a third of the time, everybody's then getting the ball a third of the time, that's fair, and this awful feeling that's both in the mind and in the body of being excluded. It's really happening, and it's happening to everybody with BPD, or almost everybody. Also, when people with BPD are looking at faces, so for example, in this set of face morphs, they can see, they can distinguish, as many people can, faces that are extremely plain and faces that are extremely happy. However, and faces ranging from happy to angry, but people with BPD have more trouble with honing in very quickly on faces that look angry. So we can prepare for that as clinicians. We can try to be cheerful. We can try to be, as many psychiatrists would be, kind of neutral, but that can get us in trouble too. People with BPD judge ambiguous faces, so ones that are maybe flat, as angry, and have more trouble distinguishing the detail about negative faces. This has changed my practice so that I use a lot more explicit language to try to narrate my emotions with people with BPD. I might say, oh, I notice that right now I'm wrinkling my forehead a little because I'm thinking about what you're saying and I really want to make sure that I understand. Or I might say, you know, I think I'm just going to sit still, and I notice that I might have a kind of a serious look on my face because I'm just processing this important thing that you're telling me. We also know that the amygdala is an important brain region for responding to fearsome stimuli. However, for people with BPD, the amygdala is at the level as if they're being faced with a grizzly bear all the time. And the level of this fear detecting region of the brain increases even further when people are looking at any face at all. So you can imagine, you think you're walking into a room and being a friendly pre-rounding student, and this person is experiencing someone terrorizing them. You can see why they might respond sort of with their hackles up. Furthermore, the prefrontal cortex, which is generally connected to the amygdala and it serves as a kind of quieting signal, you can think of it as a kind of a shh, is more weakly connected to the amygdala in people with BPD. So that calming signal, which would otherwise quiet down all that angry activation, is less available to provide that input. Let's see where we are in time. We'll show this too. So this is the trust game. In the trust game, there are two players and there's an investor. The investor gets some amount of money, let's say 20 bucks. And then they decide how much of it they want to share with the trustee. So say they decide to go fully fair, they share half, they send over $10. It triples on its way to the trustee, and the trustee then gets $30, and then they decide how much they want to return. If they return half, the investor gave 10 and gets 15 back. So you can see what's in it for the investor to give some money. What's in it for the trustee is that this is a multi-round game. And so most players would notice that if they don't return any money to their investor and they have to face the same investor again on the next round, they're going to be in trouble. So What's interesting is what happens when people with BPD play the role of the trustee. What you would expect is that if they return less round to round, then their investor partner might start to defect. And what a healthy player will do is try to reel their partner back in by over-returning on subsequent rounds. However, people with BPD here in red are almost half as likely to try to coax a defecting partner back to play compared to healthy trustees. And this is really important, I think. This is an insula signal, which we can think of as a fairness detector in the brain. And one of the reasons I say that is that if you watch this graph, and this here on the x-axis, it's the money received from the partner. So you can think of that as like how fair your partner was. And as the fairness increases from left to right on the x-axis, that unfairness signal in the insula quiets down in an almost linear fashion. This is one of the most beautiful data points this group probably ever got. But then if we look at BPD, the response to increasing money, the same changes, is chaotic. It's as if it's just getting noise. It's getting lability. It's not able to notice or respond, make use of this increasing fairness from the partner. And you can see how this could lead a partner to really feel like the person with BPD was being challenging, right? But what's the person with BPD here experiencing from a partner who thinks they're going out on a limb to help? They're experiencing terribleness. And so there's a real mismatch in experience in the same encounter. And I think this can be so useful when we think about speaking with empathy to both people with BPD and their loved ones about how to try to make it through this situation. In fact, people with BPD, here's an example of something that one person said, people with BPD feel overwhelmed with the sense that their identity is spreading into the identities of the people around them. It's hard to tell where you stop and where other people start. And also, it's terrifying. BPD is life-threatening. This idea of bleeding out is not just an idea of spreading out, but bleeding out is a way that people die. I'll make a quick note here. For those of you who would like to learn more about BPD, one way is to read about science. Another way is to read memoirs. And I strongly encourage you to think about reading memoirs of the disorders that you're most interested in learning about in psychiatry. This can be a really good way to get close to the experience if you haven't had it yourself. And there are beautiful memoirs written by people with all kinds of psychiatric disorders. In terms of treatment, there are no medications that treat BPD. There are medications that treat some of the symptoms, but we should be quite cautious because the side effects outweigh the benefits in most cases, and the more meds you prescribe, the worse it gets. That's my lay summary of the current evidence. Nonetheless, you will see people with BPD prescribed numerous medications. Over the years that Mary Zanarini was tracking this, and this looks like the most recent data I've seen, antidepressants are given to more than half of people with BPD despite minimal evidence that they're helpful, partly because we don't know, people out there are not diagnosing BPD, they're not screening for it, so they think it's treatment-resistant depression or rapid cycling bipolar disorder or some variant of a psychotic disorder or something else unusual. You can see something interesting about psychiatric history here. You can see that as second-generation antipsychotics, the ones that are less impactful on movement but more impactful on metabolism, like aripiprazole and quetiapine, and these started to become more available. The first-generation antipsychotics like Haldol became less in use. So this is actually sort of an interesting historical moment here where the dotted line decreases and the solid line increases. So I would pause on this. Though there is no medication that is FDA approved for BPD, symptoms can be debilitating. And so a kind and empathic treater is not totally averse to the use of medication in a cautious way with a plan to closely evaluate if it's helping. Also, however, symptoms can fluctuate as part of the disease. And so being thoughtful about whether a symptom is bad today and was okay yesterday and might be okay again tomorrow, and sitting with the patient to watch those undulations to decide which symptoms would merit medication is really important. Some medications, many psychiatric medications can be risky in overdose. We should think about that for people who have a history of impulsivity. However, treating symptoms is also a way to reduce the likelihood of impulsive and dangerous behavior. We should treat comorbid disorders. Often we should treat comorbid disorders with medication in BPD. Also, and I would really pause on this, adding and decreasing medications, either one, can trigger strong feelings in people in general and in people with BPD in particular. So someone with BPD might perceive being given a medication as someone really noticing and caring, and they might take that pill home and feel that it's almost a security blanket given to them by their doctor. Someone with BPD might also perceive having a medication withdrawn as the doctor criticizing that so helpful, so caring previous doctor who gave that medication, who's not here anymore. On the other hand, someone might perceive being given a medication as a comment that they're that sick and that they need this kind of thing and that we don't want to talk to them, we just want to send them off with pills. So it's really helpful to assess some of the ways your patient might be understanding and thinking about your proffers of what you perceive to be help. There are at least 4 different common evidence-based treatments for BPD. If you haven't heard before of good psychiatric management, I encourage you to check it out because it's usable. I think it works. It's psychoeducation based. DBT requires a lot more training, but it's also pretty doable in the sense that the details are quite clear. And if you follow the manual, you'll be pretty sure that you're doing it. TFP is the most sort of Freudian inspired of these psychotherapies, and I think it has a ton to offer. I encourage you to look up videos of psychiatrists doing this. You might find it a little bit harsh at first. I really think you'll find it inspiring over time. And then MBT really focuses on the idea about this separation in one person's understanding of both people's minds and the other person's understanding, and the gap that can occur and make communication so painful and difficult. So these are sort of different approaches. What I would say is that each of them starts from a different starting point. GPM starts from the idea that interpersonal problems are causing difficulty, and if we can work on that, we'll get somewhere, and that we need to get back to having a life in the community with working out and working and going to school in order to get everything better. DBT starts from the idea that emotions are out of whack and dysregulated, and that regulating emotions will allow you to get to the point where you can work on relationships and practical stuff. TFP starts from the point that your identity is sort of all spread out and sort of confused and split into extremes of good and bad, and that if you can work on that, the rest will follow. And I said MBT is about sort of the separations between knowing your own mind and others. I would say each of these get to the other stuff eventually, but they have different hypotheses about where to begin. And that can mean that they're a better fit for some therapists, and they're a better fit for some patients or therapist-patient pairs. And that's fine. It's good to get somewhere. So I've said tonight about personality that everyone has one, that it's helpful to know where the name came from and to be able to tell people. It's about being on the borderline between really feeling sort of constantly able to get by and having these times where you really can't, and then finding yourself moving between those levels of function. We can do collaborative disclosures where we talk to people using the criteria or using that 4-factor model: mood, impulsivity, perceptions, and interpersonal, as a way of assessing together if BPD makes sense and it's a good fit. We can speak directly and openly about these kinds of experiences. We can show patients data as a way to grow empathy for themselves and their families. And we can keep coming back over time to saying, you know, if we're in a GPM model, you know, you're not crazy. Your symptoms are predictable. This isn't something that's happening to you out of the blue. Your mood doesn't just cycle. Your mood cycles when you get a text from that person, or when you don't get a text from that person, or when you have to meet with your boss, or when these various interpersonal things are happening. And we can see these things coming and we can prepare for them. And you don't need to feel so out of control. We can show people data. I'd encourage you to consider, I'll send these around if you want. You can print out these slides and put them in your pocket and talk to patients about them. Give them to them. Let's get some data into the world. And as you're thinking about sort of first aid here, you can acknowledge patient strengths by using validations protocols. You can acknowledge your own limitations and set clear expectations. On the inpatient units, you might say when it's true, when you'll be back, and then do it. You might describe problems in factual, non-judgmental terms rather than saying, I think you're being manipulative. You might say, I can really see that your needs aren't being met here. I wonder what we can do about that. You can refer to an appropriate level of care, and you can provide referrals for caregivers and loved ones. And so let me just show you a few of those. So Columbia Presbyterian maintains this really beautiful BPD resource center. People can call, or you can go on the website and they will help you connect to a treater that's a particular for BPD. For any person with BPD who is interested in getting better and who would like to join a community of other people interested in getting better, there's a series of ever-growing and gorgeous programs at Emotions Matter, which include online peer support groups, writing groups, art groups, anti-stigma advocacy, tons of cool stuff. NAMI has programs about BPD, but this one is particularly awesome. The NEA BPD runs this training, which is free and run by families to teach other families to be supports, not hindrances, as people are trying to recover from their BPD. So I try to always send patients to Emotions Matter and their families to Family Connections. If you are super excited about this and you want to really invest in training, there are a number of resources through the BPD Training Institute that's now called, I think, the Gunderson Training Institute at McLean Hospital. So I encourage you to also keep this stuff in your back pocket and check it out. My last thought is that psychiatry in general, medicine in general, and BPD in particular is not something to do alone. And that peer consultation is a critical part of high quality medical care. This is a major tenet of how I practice, and it not only makes my practice more fun, it makes it better for my patients. I'm less likely to start to do something weird, start to feel weird about it, not tell anyone, and have it get weirder. Access to support can make you have a better time and can make your patients have a better time. And I encourage you, even now in medical school, to start growing the trusting communities of friends and peers and mentors who you can consult as you go around things. And I've said already tonight that your peer mentor that you can start with is Evan, who knows a ton about BPD. Also, you can contact me anytime to talk more about this. If you're on a rotation that's not psychiatry and you need help, you can always curbside psych consults. You can call them up and say, I think this is going on. How would you speak to this patient? They don't always have to be a formal consult if you just need a little bit of help. And you can go back to the patient's primary provider for support. So I encourage you to make use of those things. That's what I had tonight. I see we have 10 minutes to the hour. I'd be delighted to stick around and talk with anyone who has any questions or who would like to just sort of talk about experiences you've had. I mean, obviously we're not going to give PHI here, but we can talk about cases a little bit in general terms. I don't know, what's happening out there?
I actually have a question about how you can tell the difference between bipolar disorder and borderline personality, because I saw it mention, the depression and the mood swings, the impulsivity.
Yeah, this is a great question. Thank you so much for asking. So the simplest way that I think about this is in terms of the frequency of the mood changes. So for most people with bipolar disorder, the duration of a single episode of mania is at least 4 to 7 days, and often weeks to even beyond a month, naturalistically. Treated shorter, but still days to weeks. The duration of an elevated mood episode in BPD is minutes to hours. The number of manic episodes per year for someone with BPD is probably like 0.3 to 1 for most people. So it cycles once a year to once every few years. Rapid cycling bipolar disorder means someone is having several episodes a year. So you want to be really trying to understand, has this person had sustained periods of elevated mood with sustained periods of days in a row of sleeplessness, recklessness, being sped up? Or has it been more this undulations throughout the day of flipping through different kinds of mood states? That's one really helpful thing. It turns out that this question about affective lability is the most sensitive question you can ask about BPD. This is data from Mark Zimmerman at Brown. So if you ask someone, does your mood cycle from minute to minute or hour to hour, then, and someone says no, it's very, very unlikely that they have BPD. However, you could still have bipolar disorder. So that's where if someone says yes, then you really want to get into this understanding about the chronicity, the frequency, and the accompanying symptoms. People with bipolar disorder are less likely to have the accompanying other things that come together as a syndrome happening at the same periods of time. So under periods of emotional stress, having dissociative experience, having weird psychotomimetic experiences, having the strong feelings of identity disturbance, that you're not you, you can't count on yourself to be you, and that it's so pervasive over many years. Does that make sense?
Yes, thank you so much. That was really helpful.
This is a really important question. I'm glad you asked. What else?
Hi. Oh, I'm sorry. I just have a quick question. First of all, thank you so much. This has been such an amazing talk. I think my question relates to the physiology that you've really spoken about BPD. So, you know, we've spoken about the physiological changes and sensitivity that we know and we see in BPD, but that we don't have any medication that's necessarily proven to be effective. And yet you did mention this population of those who are in remission of BPD. So what do we know about the physiology of remission, if anything?
Come work with me. Let's find out. I really want to know. I'm really interested in this. And, you know, I think that there are things we know about the population of people who have BPD, and we don't know so much about the population of people who've remitted or predictors of remission. We know that probably there's some interaction between sensitivity to early life environment and trauma, and also other kinds of invalidating experiences that can happen in early life, some around even sexual orientation and gender identity, that mean that there's an overrepresentation of non-cisgendered and non-heterosexual people in the BPD population. And there's probably goes both ways, right? But that probably growing up, at least in the United States, as a non-cisgendered or non-heterosexual person puts you at risk of developing BPD. We don't know much about what puts you at risk of maintaining your BPD or what makes it easier to remit over time. But I'm super interested to know this. We do know that some of the physiology seems to be changeable. And one of the things I'd most like to know is what does change and what would help us predict change over time. So one study that I really like a lot is about interoceptive signals. So the ways that the brain detects the body. And there's a study where they looked at what's called heartbeat evoked potentials, which is an EEG-based measurement of the brain detecting your own heartbeat, not on a conscious level, not like counting heartbeats, but just the brain responding to your heart having beaten. And it turns out that people with BPD have a weaker heartbeat evoked potential than people without BPD and without psychopathology. But people who have remitted BPD are in the middle. And I think that's so encouraging because it suggests that plasticity of signaling in the brain can either lead or follow, and I don't think we know which, remission. I'd really like to know also about recovery, right? So yeah, Eli, do you have anything to add about that? Can I put you on the spot about remission?
I was just going to drop that study.
Oh, thanks. Yeah, please do.
Yeah, I think remission is, it challenges. I think those, when you show that like prognostic graph, it's surprising and it challenges our notion that personality disorders are enduring patterns of being in the world, which is complicated. Because it's definitionally, that's what a personality disorder is. Like in the DSM, this is like an enduring pattern of how someone is. And at the same time, we see people remit. Most people, change. So I think there's this interesting balance between. I'm not sure how to put it, because like personality traits are stable and at the same time people change. It's kind of like an essential premise of DBT, which is kind of interesting. We evaluate how someone is, and also we expect and ask you to change. And it's also interesting that that you can maybe speak to this, like BPD doesn't have the same, I think has a unique prognostic course in that a lot of conditions like bipolar disorder or depression are relapsing remitting conditions. And it seems that BPD isn't that way, that people don't go, remit and then relapse, or that's not as common.
Yeah, I'd agree.
But yeah, I don't know a lot about the biological basis of remission.
We're interested in doing, so I'll say that we have an active, so I didn't show any of our work tonight. Maybe we'll come back and do this at some point this year, but we do have an active study. We have 2 active treatment studies in my lab. One is using fMRI-based neurofeedback to try to impact on amygdala activity. And another one is to use the rapid-acting antidepressant ketamine to try to see what the impacts are in BPD. And for both of those studies, we're very interested in what baseline factors may predict response, and also what changes when people change. And we're just starting to think about even how to formulate those questions. But
one thought I had is I think the Schmall meta-analysis, and I could also drop this in, about amygdala and PFC functional connectivity and morphologic changes, is that I think some of like the gray matter deficits like are normalized in people that are on medications. And so like I just wonder like if underlying remission is some type of functional either resting state or in the context of like negative stimuli or interpersonal situations, like some normalization of PFC amygdala functional connectivity. I'm just hand waving that, but I'd be curious.
Yeah, I mean, we've also been looking at normalization of reinforcement learning signals, or potential normalization of reinforcement learning signals over the course of DBT treatment. We'll be really interested to see if we see changes in prior expectations around negative feedback or volatility or prediction errors for people who are sort of interested in that level of analysis. I'll show that out. Yeah, I really appreciate that question. I don't want to hold people past the hour, but I'd be happy to take a question or two more if people want before we close.
I do have one question. Sorry. I
think Shivani and then Josh. Yeah.
Okay, thanks. Sorry to keep you over, but so I was actually wondering in terms of kind of the presentation, I guess initial presentation of patients with borderline personality disorder, especially because I'm currently on my inpatient psych rotation,
right.
And we've run into like a number of cases where, for example, it might have been a suicide attempt or some other kind of sequela of borderline personality type, I guess, behaviors. And the psychiatrist will say, oh, like this person probably has borderline. But I mean, obviously, like inpatient, we don't, treat like a personality disorder. So I guess I was kind of wondering, like, what would be your like ideal like plan of discharge for someone like this? And I guess like how we can kind of connect people to.
Yeah, so it depends a lot on the resources in your setting. You've spoken to so many important issues. Let me try to just name them, and then we may not get to all of them, but I want to name them. One, should you diagnose BPD in the way that you would be willing to diagnose major depressive disorder? This is a generational change, and I would say almost any personality disorder trained psychiatrist or psychologist or researcher you would talk to would resoundingly say yes. This is not common practice. The reason, and so you're encountering treatment as usual, and I'm saying you probably can't fight the system as a medical student. And also, we should be diagnosing borderline personality disorder, or we should at least be talking with patients in a collaborative way about if borderline personality disorder may be a good explanation. And the reason is that the data overwhelmingly suggests that treaters are afraid of what patients might say, and that what patients usually say is, thank goodness it's not my fault. Thank goodness there's a name for this thing. I'm so relieved to hear that this thing is a thing and that it's not 5 things, and that I don't need these 12 meds, and that you can tell my family that I might get better, and that there's some hope for me. Armed with that information, I started trying to talk to people about BPD. And what I do is I print out the DSM criteria, or I take my little pocket DSM onto the unit and I say, I wanted to talk to you about something. I've been thinking about what a hard time you've been having and how many different people you've tried to get help from and how unhelpful the help has been, to the point where you actually ended up in the hospital having tried to kill yourself. That's terrible. I was wondering if you've heard of borderline personality disorder before. And some people will say, yes, I know what that is. That's other people who are terrible. And then you say, yes, do you know there's a lot of stigma out there? And I wanted to just show you the criteria. And, we've been talking a lot about things and what happened and how you're feeling. And I would walk through the criteria one by one. And as you're doing it, remember what they've told you. And if they can't quite bring to mind why you might think that they're impulsive, you might say, remember all those, I'll borrow an example from the Gunderson trainings. Remember all those parking tickets? Remember all those parking tickets you got? Maybe you were just like leaving your car without like paying the meter, or like, remember how you were saying that like you were bringing people home all the time and you didn't even like them? Remember that felt so awful to you, and you felt a lot of shame about it, and still you sort of found yourself having this experience. And I often use words like you find yourself doing, or have you noticed that you, and sort of engage them with you in observing the behavior. And then you say at the end, oh, so I see that you meet 8 of these 9 criteria. Is this how you've usually been as an adult? You speak to the pervasiveness. And some people, you start to go through the criteria, and by the time you get to the 4th or 5th one, they say, how did you know? Like, this is me. Where has this meaning been all my life? And it's not this way for everyone, but for some people, it's such a relief. One nice thing about doing the Xerox is that you can leave it with them. I sometimes also print out a 1-page memoir of someone who is in recovery and how they started to get into recovery, and I give it to them with the DSM criteria. And I say, I'd like to leave these with you now that we've talked about it, so you can think it over a little. I'd like to come back later today or tomorrow and talk some more about what helps in BPD, because people get better. And then I would talk to them about the treatments that are actually available to them. Things that are available in your area. Is there a DBT program? Is there something online? What will their insurance pay for? Don't dangle things out that they can't actually get, but learn a little bit. You can ask the social workers, what are the available resources? And you can tell them. But I would really argue again, and don't do it without talking to your attending, right? But or your resident, but if you can get them on board, talk to people and tell them. And as you get further along in training, talk to people and tell them. And I think Evan can probably send around to people afterwards some of the links to the videos that show how to do this kind of diagnostic disclosure. It's really powerful, and it's not that hard. And I think that what you'll find is that, to your surprise, people are relieved. Does that answer your question, Shivani? I know that I sort of went a little bit off script, but I think this is important to know. Yeah,
that was super helpful. Thank you so much.
And invite people to join you in figuring out if it makes sense. If somebody says, no, that's not me at all, I would say, okay, well, help me understand what's different. And maybe you just start the conversation inpatient. But maybe you try, if they don't have a therapist already, to send them to someone who could work with BPD, if that became the thing that was the name, right? Not someone who primarily works on major depression and doesn't feel comfortable with BPD. Maybe someone with BPD, you try to send them to a clinic where there's sort of a surround of providers rather than one isolated person trying to manage overwhelming affect. That would be something to think about. And if someone's a little further along and ready for it, send them to Emotions Matter to get a little bit more support and to join as sort of being a peer advocate. That can be a really powerful experience too. But the most important thing I think would be to just say, like, this makes sense to me. You're not saying something that sound, I know people might have told you that, these emotions don't have root, don't have a place, but what you're saying makes sense to me. I've heard other people say this, it sounds awful. Rather than saying, did you threaten to commit suicide? You might say, did you tell anyone you were going to hurt yourself because of how much pain you were in, right? Try to use non-judgmental and non-stigmatizing language. That can be a really way into sort of joining with people in understanding their experience. Let's see, I think I can take 2 more questions. I think Josh had a question if you still want to ask. And then I see a couple more hands, and then people can write to me after too.
Sure, yeah, thanks for remembering that I had my hands up.
Yes.
I'll try to keep it short, but I'm interested in sort of I guess understanding the narrative identity issues in borderline personality disorder, because I think that like giving information to patients in DSM terms and sort of destigmatizing things is a really palatable way to understand these like personality problems that they're experiencing. But at the same time, from what you described with this issue in like narrative identity and disturbance of self and interactions with other people, like part of it kind of seems like this Langian sort of self-induced spiraling behavioral pattern that is almost like reminiscent of like schizophrenia to me, like in the sense that it's just partially a cause of this like sort of excessive spiraling way of thinking and behaving. And so like how do you like reconcile, not necessarily in public forum or with your patients, but I guess as a psychiatrist, how do you reconcile those two aspects of something that seems kind of biological, but also kind of like psychological? Like where does your understanding lie?
So Eli and I have been thinking a lot about this. Eli, can I ask you to talk for just a moment in response to this really nice question? One thing I'll point out is there's some really nice work on narrative from Sass and Parnas in the schizophrenia realm, and we've tried to engage with that, but we've thought about it a little bit differently in the more attachment frame. Eli's been writing on this. Do you want to try to say something about this question?
Yeah. So I guess when I think of like the term narrative identity, it's like the story we tell about ourselves and the kind of person we are and the kind of goals and values we have and how consistent they are and the extent to which we live in accordance with our goals and values. And are those goals and values like internally generated, or we have, if our goals and values are tied to certain types of interpersonal needs or certain types of approval or validation. If who you're with is changing, then your goals may change and that may feel unstable. This is there. I'm interested in how some of these alterations of narrative identity are related to embodiment. And there is some interesting research about some of these interoceptive deficits that we've been talking about, how our brains process internal bodily signals, which is kind of like the biological basis of emotional processing. If our brains have difficulty trusting these signals or processing these signals, it may be confusing. And this is a condition called alexithymia, where some people say, I just feel so uncomfortable, I don't know what I'm feeling. And if you're feeling that in the moment, over time, that can lead to a lot of discontinuities in internal experience. And also whether, emotions are mine or if they're my partner's, and like, where do I, is what I'm feeling my own emotions? Like, am I feeling agent and what implications it has for sense of agency? And from a personality organ, from a psychodynamic model, it's really a dimensional assessment to what extent, identity is so disorganized that it's psychotic. If you're in a psychodynamic frame. How is this different than self-disturbance and schizophrenia? When I read like Parnas and Sass, I don't know if people are, it's, these Europeans doing phenomenology, and, they described self alterations in schizophrenia as this more basic, like ontologic insecurity. Like, I feel like my world is ruptured and I don't understand, like, metaphysically, like, what's happening. Is this kind of like prodromal experience, like before someone's like psychotic, it's like, wait, I don't understand how the world is working right now. And there's this grasping to like make sense of the world in some like, ontologic sense before like delusions form. That's my sense of like how people talk about selfhood differently in schizophrenia.
About time.
Sorry, I don't know if that's.
Yeah, what's that stuff about time, like that people don't feel that there's a moment outside of the current moment. One can't imagine feeling differently than they do right now. They can't imagine having the continuity of self from past to future. It can be very hard to have hope for the future if you're sort of not able to imagine that it's sort of part of that you exist beyond the current moment. It can be that sort of issue. Yeah, so I see we're coming up on 8:15, and I imagine that some of you have had a long day of many Zooms. So we'll invite people to relax a little and get on to the rest of your evening. I'm sorry we couldn't get to all the questions, but I am just so grateful for all of you and your interest, and I hope that some of you might reach out to ask more questions or to talk about coming up and doing some work with us. It's really been a pleasure to be here and to hear all the questions, and another round of applause for Evan, because awesome idea, and thanks for pulling everyone together.
Thank you so much for giving this talk. I was so excited about all the questions that people were asking that I thought were just spot on, and I think reflect that this was a really good talk that got at what medical students really need to know about the disorder. So thank you so much. I'm really happy about how this turned out.
All right. Have a lovely night, everybody.